Hey everybody, with North Carolina MTAC. I'm Chris Kuppler. I'm one of the trauma surgeons here at Carolina's Medical Center here in Charlotte. Just wanted to go over some quick things about kind of the chest x-rays that we get down in the trauma bay and the main things that we're looking for on those. So big things that I want to know, three things: A, big air; B, big blood; C, big mediastinum. So when I'm looking at a chest x-ray on a trauma patient, first I'm looking for big air. So I'm looking for a large pneumothorax so that I can, if I need to put a chest tube in that patient, I will be able to intervene on that quickly. So big air, I would be looking for some air out here on the outside of this, between the chest wall and the lung here. And that's a indication that the patient might need a chest tube. Big blood, and the second thing that we're looking for, I'm looking for basically a large amount of blood in the chest. If the patient was shot, or if they have rib fractures and have a lot of blood in their chest from maybe a ruptured intercostal artery, I'm looking for that might need to be drained out. And that would cause some more whiteness on one side of the chest versus the other. You'd see a lot more kind of haziness or opacities over here that might indicate that the patient has a good amount of blood in their chest. Third thing is big mediastinum. So I'm looking at the patient's mediastinum here and trying to figure out if that's wide. Definition for what a wide mediastinum is changes from source to source, but generally about 6 to 8 centimeters is considered a wide mediastinum. That can be a hallmark for major vascular injury or aortic injury, and so there's other things that can cause those, but big things, or there's other things that can cause a wide mediastinum, but the biggest thing that I'm worried about as a trauma surgeon is an aortic injury that might need to be intervened on immediately. Other things that we can look at when we initially take a look at this x-ray from one of our trauma patients, I'm looking at their airway to see if it shifted one way or the other. That can help me determine if there's a tension component to a potential pneumothorax. I'm also looking, if the patient does have a breathing tube, I'm looking to see where that breathing tube terminates here in their airway. I'd like it to be 5 to 7 centimeters or so above the carina, to make sure that with patient movement and everything, that they're not going to get main stemmed at all and have the tube just go down one main stem bronchus. Finally, another thing that I'm gonna look at over here, we have some x-rays. This was a victim of penetrating trauma, gunshot wound to the thoraco-abdominal region. And so I'm looking at where my markers are, the paper clips. So an open paper clip would be a posterior wound, and a closed one would be a more anterior wound. I think we have some open paper clips further down on this. These two are both closed, but those are helping to identify ballistic injuries so that we as trauma surgeons can figure out the path of the bullet and figure out where we might need to go in the operating room to help fix an injury, whether it's in the abdomen or chest. So hopefully those basics will kind of help you with looking at chest x-rays in the trauma bay, and thanks so much.